Welcome. I'm Peter Kern, the Director of the Global Health Program, and I'm just thrilled that we have another and a really exciting lecture series ready for you this year. This is, I think, the fourth year that we've had this Global Public Health Lecture Series, and each year we have a different group of speakers, and they're all just really fascinating and just amazing, the kinds of things that they've done in other parts of the world, and in some cases here in this country, in areas that really need extra help. Last week, you didn't miss anything if you weren't here, because that was just me, and I just introduced the course, and so this is really the first lecture in the lecture series, and it's really going to be a good one. So I'm happy to be here to introduce Kate Hurley to you. So Kate has a Bachelor of Science in Nursing from Emory University and a Master's in Business Administration from the University of Montana and a Master's in Nursing from South Dakota State University. So as you can see, she's been around.
I love school.
Her background in nursing has been varied and exciting. She's been able to work clinically in both intensive care and emergency nursing. She likes working in clinical research, doing consulting as a legal nurse, healthcare management, and education. She's taught at Montana State University College of Nursing, both in the undergraduate program and in the graduate program, teaching both management and clinical courses. I think one of the things she's going to talk about tonight is the work that she's done with WHO in Africa during the Ebola outbreak, caring for Ebola patients, followed by the training work that she did in Cuba. And so with that, I ask you to join me in welcoming Kate Hurley as the first lecturer this year.
All right. Thank you very much. And by the way, nice to meet you. We've emailed each other back and forth a lot.
I'm not going to shake your hand because I got a cold.
Okay. So anyway, I had the tremendous opportunity in 2014 to go to West Africa during the height of the Ebola crisis with the World Health Organization and work in an Ebola treatment unit. And following that experience, that was a 3-week experience, I then came back to the United States. I worked at St. Pat's in their ICU, was back in the United States for a week, at which time they needed myself and another physician who went from Missoula, Dr. George Reese. They needed us to go to Cuba, to Havana, and teach 200 nurses and physicians who were going to be deployed to the very same hospital in Kinema that we had spent 3 weeks in. So then I got to go to Cuba. That was a tough one. And work for a week educating physicians and nurses. And then sort of as part of this whole experience, I went to a clinical research meeting at the NIH because Dr. Reese, who is an infectious disease physician here, was unable to go, so I went as his proxy, and there were lots of ethical issues we talked about at that meeting in terms of what to do with clinical research, in terms of Ebola vaccine, in terms of treatment, and how that all should work. So all of those experiences coalesced into my being invited to be a panelist at the Presidential Commission on Bioethics about Ebola. So, long story. But what we're really going to talk about at the end of this time is kind of the global health planning that happened as a result of all the testimony that happened at the Bioethics Commission. But in order to get there, I need to give you a little bit of the history and the backdrop of the Ebola crisis and some of the issues therein. So we're getting there. It's just kind of a circuitous route. Let's see. Do I hit? So how many of you remember anything about this Ebola crisis in 2014? Anybody have any memory of the blast day and night on the 24-hour news channels. So we're just going to go over a little bit of what it is, what's the clinical spectrum, some of the manifestations, the treatment, the outbreak in West Africa, because that's all going to tie into some of the recommendations that came from the Presidential Commission. So, long and short of it, the Ebola virus was first discovered in 1976 in a small village on the bank of the Ebola River, Zaire. There were 318 cases, 280 of those people died, huge mortality. There was a simultaneous outbreak in Sudan. It's found to be 2 different species of the virus. There are actually 7 different species of the Ebola virus. The one that was most commonly treated in West Africa was the Zaire, and it was named after the river because that's where the first case occurred. So there was the outbreak in 1976, but you know, the next decades there were other outbreaks. They were smaller. You know, you can see they go all the way through Uganda, Gabon, Congo, Uganda. And then in 2013 is the first time that we see it in West Africa, and we'll look at a map in a few minutes. And so some of the issues with the way the Ebola virus, I think, was perceived when we had the outbreak in 2013 and 2014 was because of some of the books and the media and some of the, I mean, how many of you saw the, well, you're probably dating myself, the movie Outbreak with Dustin Hoffman, and you saw it, I know.
I haven't seen it.
Yes, you have. Anyway, you've seen it. So there were movies that kind of talked about Ebola, but they didn't give it any justice. And The Hot Zone was one of those books by Richard Preston. So why did we see more and more of these Ebola outbreaks? You know, we probably were had much improved surveillance, increased interactions between humans and the reservoirs, and we'll get to that in a minute, habitat destruction, and climate change. So Ebola is really a viral hemorrhagic fever. That's what it is. It's a hemorrhagic fever. And they're maintained in a variety of animals. Now the animals may get asymptomatic. They may be asymptomatic or they may have low-grade symptoms, but they don't develop the same symptoms that humans do. And that's because humans, from an evolutional standpoint, were never ever intended to have the Ebola virus. But what happened is there's some sort of contact with the blood or tissues from an infected animal, and when the virus gets into our bloodstream, we have no antibodies, and so as a consequence, patients get incredibly, incredibly ill. There is a little bit of issue with inhalation of aerosolized secretions, so it's not really moved by droplet per se, but if you're taking care of a patient and they're coughing and they're sneezing, it can aerosolize in those droplets. So when we were in West Africa, we used N95 masks just because that was a possibility, and we'll get into that in a minute. So what happened is that somehow humans came into contact with the virus from animals, and then the Ebola virus developed to be very deadly in humans. Now, the biggest purveyor of the disease is the fruit bat. The fruit bat in West Africa is considered a delicacy. So they eat it, they cook it, and if it's cooked rare, and the fruit bat has the virus, it can get passed on to humans. So that's one of the transmission vectors for the virus. They're kind of ugly looking, aren't they? So this is kind of the life cycle. Following, you know, you'll have a bat, you'll have a primate, they have the virus. Somehow they bite a human, you eat a fruit bat, something happens, and the human gets the virus, then they develop Ebola. And the issue with Ebola is it's incredibly contagious. It's as easy to kill as the norovirus, which is the flu. I mean, it just takes some chlorine, but it's incredibly, incredibly infectious. And I should look at my time, okay. So, previous to the outbreak in 2013 and 14, if you look at where these outbreaks are, they were They were all, you know, up in Gabon, they were along the equator, some in Congo, but there were none in West Africa. And so what happened when the outbreak happened in West Africa is people really didn't know what was coming because they hadn't seen it. I mean, they'd seen it in all these other red areas that you see on here, but they'd never seen it here in West Africa, which was part of the issue with the lag time in getting treatment, getting the World Health Organization involved, and getting people mobilized because they didn't have any institutional knowledge of Ebola. So the progression of the disease, one of the issues with Ebola is it's got a long tail. So if I am working, say I've been in West Africa, and the last day that I work with somebody who's potentially infected, I can still get the disease and have symptoms 21 days out. So it's got a long tail on it, which is tough, became very tough, as we'll talk about, relative to quarantine and restricted travel and those kind of things. Most people will see symptoms in 7 to 10 days. So it starts out with fever, vomiting, watery diarrhea, headache, rash. Now that manifests as many diseases in West Africa, malaria. So people were just sort of slow to say, oh, what's going on here? Then it goes to nosebleed, bleeding gums. It really, really is a hemorrhagic disease. And you might see clinical improvement in 7 to 10 days. And then oftentimes you see death in 6 to 16. And that's just followed by the issues you have with hemorrhage. Because people just bleed from everywhere. And so they'll have shock, DIC, multi-system organ failure, and hemorrhage. And we saw all of that when we were in West Africa. So this is a picture that was taken back, I don't know when it was taken. It was not taken in the Ebola treatment unit where we worked because we could take things into the Ebola treatment unit, and we'll get to that in a minute, but we couldn't take anything out. So we couldn't take in a camera. We couldn't take in a notebook. We couldn't take in a walkie-talkie. We couldn't take in a phone. So we have no real pictures of what the inside of the Ebola treatment unit looked like, but this is very, very, very close. Concrete floors, metal bed frames, mattresses, buckets by the beds, no sheets. It was very, very, very third world. Because it is. Oh, and what this is a patient who has one of the very classic signs of a hemorrhagic fever, and that's hemorrhagic conjunctivitis. It's just bleeding inside your eyes. Okay, so the outbreak in 2014. This map does a nice job of showing where it is. It was in Sierra Leone, Guinea, and Liberia. I spent the bulk of, I don't have a pointer, but the Ebola treatment unit that I was deployed to, which was the largest one in the country, was right here in the middle. There was another Ebola treatment unit that was run by Doctors Without Borders in Calhoun. Freeport's the largest city in Sierra Leone of about 5 million people, but it hadn't really hit Freeport yet, so there were no Ebola treatment units in Freeport. It was also in Guinea and Liberia. And if you look at all of Africa, this is a small little area that was hit by this epidemic. So really, Sierra Leone was ripe for some sort of, for this Ebola outbreak. There had been so much internal conflict for many decades in Sierra Leone with civil wars that happened in Liberia, internal conflict in Guinea. Guinea had numerous refugees that came from Sierra Leone and Liberia. In fact, one of the things that really perplexed me when I got to West Africa is there was we were in the town of Freeport, and we'd gotten in the night before. The next day, we're trying to find the World Health Organization and get all of our clearance papers. This is a town of 5 million people. There's not one stoplight, not one stop sign, nothing, because during the Civil Wars, all of that infrastructure was gone. So much of the infrastructure in the country was gone because of the Civil Wars. porous borders between the countries. I mean, people just wander from one place to the other, and they're in Guinea, and then they're in Sierra Leone. I probably should have done a little more research before I went to Sierra Leone, but I didn't. So as we're leaving Freeport to drive with the World Health Organization to Kenema, which is a 5-hour drive, we're on this just beautiful highway. I mean, it is nicer than the road from here to Spokane. And I'm sitting, I'm kind of thinking, I'm like, God dang, no stoplights, no stop signs, you know, street markets, and yet we have this like beautiful freeway. So I look at Dr. George Reese, who was with me, and I said, riddle me this, Batman, what's going on here? And he goes, well, think about it for a minute. What else do you have in Sierra Leone? What else is in Sierra Leone that would mandate having highways like this? Diamonds. And so you had these major highways that went back and forth across the country, which of course made the people in the country much more mobile and spread the disease throughout the country. Anyway, just an interesting fact. I didn't realize when I went over there. Very inefficient healthcare system. Healthcare workers were not trained how to protect themselves because they had never worked with Ebola before. And there was also a high level of resistance. A lot of people in these 3 countries felt like the aid workers brought the virus with them. And so there was a lot of resistance to bringing people into the Ebola treatment units initially. Okay, let's get going. Okay, how did it start? In doing some epidemiology, they think it started with a 2-year-old boy in Guinea. He died in a village in Gekadu, and they think he was exposed to a bat. Then his mom and his sister and his grandmother become ill and die. So now we've gone from 1 case to 4 cases. And then friends and relatives arrive from around the region. And one of the reasons the virus spreads so quickly in these countries is the way that they prepare people for burial is they bathe them, they dress them, they sleep with them the night before. I mean, that's just their ritual. And here are patients who have been sick, nausea, vomiting. So it just became rampant through the country because of burial practices. Went to multiple other villages, and then it was off and running. Okay, so let me tell you a little bit about how I ended up going to Sierra Leone. So I was managing the ICU at St. Patrick Hospital, and I was working with an infectious disease physician there, Dr. George Reese, and he was a physician liaison with the Rocky Mountain Labs down in Hamilton. How many of y'all are familiar with the Rocky Mountain Lab? BSL-4 lab. What happens at BSL-4 labs? What do they do there? They study viruses and diseases for which we have no cure or treatment. Okay, there's really only 4 of them in the United States. There's Rocky Mountain Labs. There's one in Atlanta with the CDC. There's one in the at the NIH in Bethesda, and then there's one in Omaha, Nebraska. Okay, so one of the things that when they put the Rocky Mountain Lab in place, the NIH gave money to St. Patrick Hospital so they could retrofit 3 of their rooms and make it into a self-contained care and isolation unit, such that if one of the researchers or visitors to the Rocky Mountain Lab somehow became infected with one of these viruses and pathogens for which we don't have a cure, they could be treated at St. Patrick Hospital because we had this self-contained care and isolation unit. So Dr. Reese and I did a lot of training for the nurses and for the physicians. We had people that came from out of state in terms of how to deploy and use our care and isolation unit. Now, mind you, we'd never done it. But during the height of the crisis, George had friends in the World Health Organization and said, you know, we really need volunteers. Why don't you come? So George said, okay, why don't we go? I'm like, sure, let's go. I had no idea what I was getting into, none. You know, I sent him my CV. We arranged with another physician that we both had worked with who was in Boston, Nahid Bedelia, and we found a 2-week period in August and September that we could both go, a 3-week period. So off we went to Sierra Leone. And we really thought that we were going to sort of be there in a consulted, you know, as a consultant, kind of helping them figure out how to put the stuff on and wash their hands. It's not what happened at all. So anyway, But it was a good, it's been a good experience. So that's how I ended up going. So it's a long, long flight to Freetown. And the scariest, I thought this was going to be the scariest part of my entire trip. So we land in this tiny little peninsula, and it's dark, and they're taking all of our bags out, and this little boat is just, it's sunk down to, truly, I can put my hand outside the rim and I can feel the water. We have little life jackets on. It's dark. We have to go across this rough bay. Truly, the waves are just crashing over. And I'm just, I'm just like, I'm not even going to make it into Freeport. But we survived the water taxi into Freetown, not Freeport. And then we went from there. So this is just a picture of what the city looks like. Sits right on the ocean. It's a city of 5 million people. And this is Sierra Leone. The people, a couple of things happened. I fell in love with the people. Just an incredible culture. Just gracious, beautiful, fun, always happy. Always happy. Even when they had Ebola, truly, they were happy, always smiling. And the women carried everything on their heads. And George tried, but wasn't very successful. And then this is, when we got into this Ebola treatment unit in Kinema, it's, like I said, it was about a 5-hour ride. The next day, this was our little office, and I had no idea it was going to be such an international endeavor. We had people with the World Health Organization there doing epidemiology, surveillance, infection prevention. We had a logistics guy, Dario, who could find you anything, anywhere. He was the most valuable person on the entire team. He could find you red wine. He could find you diapers. He could find you fabric. I mean, he could find everything. So he could find you cigarettes. Not that any of us smoked, but I mean, he could find anything you wanted. So it was a very international group. These were all World Health Organization people. We had a triage center outside of the hospital, and that was run by the American Red Cross. And then all of our labs were run by the CDC. So you had the CDC, the World Health Organization, the American Red Cross, then you had local nurses, and you had local, for lack of a better word, we called them porters or hygienists. They took care of cleaning the facility and helping us deal with patients who died. So we had both international and national people working with us. So this is the hospital. Now, you have to remember, this is a government hospital. It was before it became an Ebola treatment unit, they had a surgery suite. They had 2 or 3 surgery suites. All the babies in the region were delivered there. Everybody got their medical care at Kinema General Government Hospital. As soon as it was taken over as an Ebola treatment unit, there was no place for anyone to get any of that care because all we could do here was treat people with Ebola. So you have all these people living out there in the community that have no place to go for health care. So, I'll go through a couple more slides here. So I just want to tell you a little. So when we were working here, we had some hot zones where you had to have your personal protective equipment on, and you had some cool zones, and then you had some cold zones. The cold zones you didn't have to wear your personal protective equipment. The kind of cool zones, you had to wear part of it, and in the hot zones, you had to have full gear on. So the little office you saw earlier is the office. Out in the front, there was a triage tent, and that's where people would come in off the street who thought they had a fever, and they were triaged by the Red Cross, and many of them came into the Ebola treatment unit. We also had an ambulance bay, and that was kind of a cool zone. What happened is because in Freetown they didn't have an Ebola treatment unit, we would during the day sometimes get ambulances full of 5, 6, 7, 8 people, all in the same ambulance. Some of them may have had Ebola, some of them did have Ebola, but certainly by the time they got to our treatment unit, they all had it. And so they would come into sort of the blood draw station, local phlebotomists would draw their blood, and the CDC would run it, and we'd put them in the suspect ward. Now the suspect ward sounds pretty fancy. Concrete floors, mattresses on the floor, buckets, big nurses station with our meds, and that was it. And so somebody in the suspect ward could be as asymptomatic as I am now, or they could be just incredibly symptomatic. But we couldn't put them in the confirmed ward until we knew if they were positive for Ebola. We did have a couple of people that came in that we thought had Ebola, and they really had malaria. So it would have been tremendously grievous to put somebody with malaria into the confirmed Ebola ward. One of the biggest issues we had is sometimes we would have parents who were in the confirmed ward, but their kids came in later and they were in the suspect ward, and trying to communicate with the family members to keep them separate, because there were no barriers. I mean, we basically, as you looked at those pictures, there was just a rubber fence that would fence off the areas. And then the last area over here is the recovery ward. We'll talk about that in a few minutes, but that ended up being the most joyous place in the entire hospital. And then down here is where we'd change into our stuff. We'd go through, we'd take care of the patients, we'd come out through the recovery room, recovery ward, and then we'd spray and we'd take off all of our personal protective equipment. Just some more pictures. This is, we had some overflow tents outside the suspect ward where we often had to keep patients because we just didn't have any room in the hospital. So these were among my favorite people. These were, I guess we call them the hygiene force or the porters. They were great. I mean, I would come out after being in the treatment unit for 2 hours or 3 hours, and we had to take all of everything off in a very specific manner, the exact same way. And you had a buddy who watched every single thing you did. And so if you started doing something wrong, they'd stop you. You'd get all of your stuff taken off, and then you'd have these hygienists with just buckets of chlorine on their back, and they would just spray you down in chlorine. And we did that. Sometimes we'd go in and out of the unit 3 and 4 times a day. And they were also the people that would put on protective equipment and come in and clean the ward 3 and 4 times a day as well. The reason you see them all gathered here is one of the issues that we had in Sierra Leone is sometimes the local workers would go on strike. Even though these countries were getting money in, just money, aid money, sometimes it was difficult to get it disseminated down to the workers. So these workers hadn't been paid for 3 weeks. And so they went on strike, and I don't blame them. And so the World Health Organization remedied that and paid them all their salaries, and they came back to work. The nurses went on strike too for the same reason. So lots of political issues intermingled with the health issues. Oh. Okay, so these were the hotel rooms we stayed in. So Dr. Easy and I, in our great wisdom on the way over there, took huge bags full of scrubs because we just knew we'd be wearing scrubs every single day. And we put all the scrubs in one bag. And I didn't put any scrubs in my regular bag. Of course, George put in 3 pairs because he's more organized than I am. So we get to Sierra Leone, and the big bag with all the scrubs is not there. So I look at George and I'm like, "You got a couple pair of scrubs, don't you?" And he goes, "Yeah." I said, "Can I have them?" He goes, "If you wash the scrubs every day, you can wear them." So anyway, so for the first week we were there, we had to wash our scrubs every single night and then rewear them the next day. So that was me washing scrubs at the end of a long day. So this was our changing tent. This is Dr. Easy. We all wore irrigation boots. And the reason we wore irrigation boots is once we got inside the unit, she was just wading through stuff. And so we wore scrubs, and then we would wear the white PPE suits. And I won't. So we'd wear the white PPE suit, then we'd put on our hood, then we'd put on an N95, which would protect you from respiratory droplets if you had them. Then you'd put on the face screen, you'd put on the apron, and you'd put on 2 pairs of gloves. Now, you never touched your face, you never scratched anything, you never had a drink of water, you never did anything. Once you got in this stuff, you were in it for as long as you could tolerate it. What happened is it was about 90 degrees No, it was about 90 degrees and 90% humidity. So it was kind of like running. You know, the first time you go out running, God, you can go like half a mile. And then once you just keep doing it every day, then you get better. So by about day 3 or 4, we could all stay in the PPE for 2 or 3 hours at a time, and sometimes we'd go in 3 and 4 times a day. So, but you always had a buddy, and your buddy was always watching you. And if you were doing anything that was unsafe in terms of contaminating yourself, you know, your buddy would tell you or you'd go out. At one point, I was in the Ebola treatment unit and I backed up against a nail that was in the wall and it tore a hole in my suit. I immediately left and decontaminated myself and took a break and went back in. So we were I think the reason none of us came back with Ebola is we were very, very judicious. So there was Dr. Reese and Dr. Nahid and Nurse Kate, and that's how, you know, they knew us because the patients didn't see us. I mean, the only way they could tell who we were is by our height and our body build. So this is how we'd go to work every day. Very glamorous. So this is 10 days into deployment, and it's just, you get there at 8, you look at all the lab work, you determine who's, you know, positive for Ebola, who's negative for Ebola. You look to see what the ambulance brought in the night before. Did all those patients get their labs drawn? And then you'd start. And you just do the same thing day after day after day. So it seemed like it would be kind of boring, but every single day, I tell you what, there was some sort of crisis. I mean, one day, we had a nurse who was working with us who was from Great Britain, who ended up getting Ebola. So we had to figure out how to get him back to Freetown and get him air-vac'd back to Great Britain. We had another epidemiologist who was from Germany who was working with Doctors Without Borders in Calhoun who came down with Ebola. So he came to our unit for treatment, and then we had to figure out how to get him, because we don't have a lot of resources. So we had to figure out a way to get him to Freetown and then get him over to Germany. One of the people in our group inadvertently stabbed her finger with probably a sterile needle. But still, we didn't know. So we had to do the same thing. So every day there was a crisis. You know, the nurses would go on strike, or the hygienists would go on strike, or something. So there was always something going on. And this was probably the highlight for Dr. Reese, is that the director of the CDC, Tom Frieden, came and visited us in Kinema. And so the night before, we all got together to think about what we were going to tell Tom Frieden. It was really kind of a cool experience, especially for those people who were deep into infectious control.
You might mention that now George is working at
Yes, he
CDC.
is.
He gave 2 lectures on Ebola, and now he's gone to, we've lost him.
We've lost him, and he's actually working in Washington, D.C. for an arm of the Department of Defense called BARDA, where they look at funding for different small pharma companies and large pharma companies that do research into resistant bacteria medications and vaccines. So he's really loving what he's doing, and he's traveling all over the world. So I only survived being in West Africa because of George. So the outbreak, it was an overburdened public health system. We talked about some of these things. Insufficient numbers of treatment centers. Sometimes we ran out of PPE. At one point we didn't have enough aprons. We ran out of aprons. So our logistics guy found a seamstress inside the city of Kinema who sewed them for us out of plastic. So they were very crafty. And it was a very decentralized response. So we talked about the outbreak challenges with burial customs. Lots of education had to take place. And so when the porters or the hygienists would come in, they would usually, so we would all kind of huddle in the morning. We'd go through all of the lab results. And the only labs we looked at were their PCRs to see if they were positive or negative for Ebola. And then we'd usually somebody would sort of stay behind and work with the CDC on some lab results, and then we would go in and we'd start our whole day. But the hygienists would all come in much earlier than we did, and they would remove all the patients who died during the night, because we as clinicians would be there from about 8 in the morning until 8 or 9 at night, but then we weren't there overnight. I mean, the local nurses would be in working with patients, and you'd have the hygienist in there, but we weren't in there overnight. But we could pretty much, with a fair amount of certainty, when we would leave at 8 o'clock at night, we'd pretty much know who wouldn't be with us the next day. So these guys worked these men and women worked really, really hard, and then they would then, a lot of the bodies, I think, because we couldn't find family members to bury them, they were burned because they were such a huge source of infection. So clinical impressions, this was kind of the strange thing about being there, is sometimes people would come in and they'd have a positive PCR for Ebola, and they would never be very sick. They might be a little nauseous, they might be a little achy, but they'd be fine. Then you'd have other people that would come in. We had this brother and sister, robust. I mean, most people in West Africa are real thin, slight people. These brother and sister weren't overweight, but they were good-sized people. They were healthy, and my goodness, they came in one day and they were not with us the next. So I mean, George and I, we didn't know if there was some sort of familial tendency that made people more susceptible. Of course, there was a high mortality rate among children. We were really intense with our IV resuscitation. There's, in medicine, when people have sepsis, we call it surviving sepsis campaign, and you just give patients, when they're septic, just an inordinate amount of IV fluid. And so that's really the protocol that we adopted. Even though it was a virus, not a bacteria, we hydrated them, controlled their fever. We did have some IV Valium that we sometimes could give them to control their agitation. And we had some Rocephin that we could give them if they had some sort of translocation of bacteria somewhere, but that's really all we had. And it was not very sophisticated. And so what would happen is we'd get IVs in these people, and then as soon as the bag was empty, you'd go to put another bag up, and they'd just pull their IV out. So then you'd have to start all over again. So I finally got to the point where, I mean, you've got all this garb on, and you got 2 pair of gloves, and you don't have an IV pole. You have a nail in the wall that you're hanging the IV bag on. And so we had a couple of young women that spoke English in Mandalay, and so they would go as our interpreters and often tell patients, if you take the IV out, that's it. So then they would leave it in, but there was such a cultural misperception about what we were actually doing.
I think that was a great approach, because you might remember that in Nigeria, where they had a few cases, that was the approach that they used, and they were able to stop the spread of Ebola very quickly because they really used massive rehydration.
Mm-hmm. Right, and I mean, I can't speak for Doctors Without Borders because I haven't worked with them, but my understanding is that the philosophy between the World Health Organization and Doctors Without Borders and treating these people were different. I mean, if we could orally rehydrate people, we would, but we were very aggressive in getting IVs in, as long as we could stay safe. Okay, sometimes you'd have a patient who was combative and agitated, and the risk-benefit just didn't work because I couldn't get stuck with a needle. So, but our mortality rate we felt was about 40 or 50% with the aggressiveness with which we were working. Of course, the experience in the U.S. is totally different. Healthcare is very different. But a couple of the patients that came back to the U.S. were very, very sick as well. So this is what kept us going. This is what kept us going. So, I told you about we had the suspect unit and the confirmed unit, and we had the recovery ward. And the recovery ward was really just a big tent. It was an old cholera unit, and I don't remember cholera, but they were big. They were just big stretchers with a big hole in the middle because cholera and constant diarrhea. And so it was a big tent with all these just beds across them. All these patients were in the recovery ward. They were just waiting for their PCRs to come back negative. And they'd have to have 2 PCRs that came back negative before we could discharge them. And these are people who were down in the recovery unit. Margaret McCulley, I have to tell you a little bit about her. She was in the suspect ward with her husband, and he fell off of a stretcher and got a subdural hematoma and died. Margaret ended up being positive for Ebola, moved to the confirmed unit, and by day 2 she was coming up to me saying, "What can I do? What can I do?" And so we had taken all these young children who didn't have parents and kind of put them in the back pediatric room. And these kids did okay during the day because we were around and there's a lot of staff around. But then overnight, there was nobody watching them. We didn't know if their nausea was getting worse. And so Margaret adopted 3 of these children while she was in the Ebola treatment unit, took care of them, and got them out to the recovery ward. So just tremendous person. Isaac Conte, his mom and his wife were both in the Ebola treatment unit. His mother died. Isaac was a nurse. And he and his wife were going to adopt a couple of the kids from the recovery unit that didn't have parents. So the people were just tremendous. This is one of our physicians, Dr. Ian Crozier, and he was like the Pied Piper. The kids just followed him around everywhere he went. This is, we worked real closely with the CDC, and they really never came into the Ebola treatment unit. But they knew there were a lot of kids, so they would bring candy. We'd bring candy into the kids, and they'd never had Pop Rocks. So this is where we were giving all the kids Pop Rocks, and the CDC were standing on the other side of the unit taking pictures. And this is Victor and his brother Ibrahim and Shaku, all 3 brothers who lost both their parents, but they were just the nicest young kids. And this is Edith Wilson. That really was her name, Edith Wilson. She was my little interpreter for much of the time I worked there. Why do you think she has that big grin on her face? Just found out that she was negative for Ebola and she got to go home. So, one of the things that people didn't see much in the news were the survivor stories, which I think was kind of a travesty, really. So what we would do is we'd finish all of our work in the suspect ward, we'd finish all of our work in the confirmed ward, then we'd come down to the recovery ward, and we kind of made it like the Academy Awards. We'd stand in the front, we'd read off their names. They were negative for Ebola, and they all, a lot of them didn't really have homes to go home to, but they knew they didn't have to stay there anymore. So these people are all people who were negative for Ebola and got to go home. This is Dr. Isi, myself, Ian Crozier, another physician, one of the best nurses I've ever worked with in my entire life, named Isaac, and a young survivor who was going home. And this, just as a picture, is you got closer and closer and closer to the epicenter of the outbreak, there were more and more and more checkpoints. In the first few checkpoints, we didn't worry about too much, but as you got into the center, oh, they had machine guns. I mean, if that World Health Organization badge of mine was my favorite thing the entire time I was there, because we would all just take our badges and put them out the window and turn our head, and they'd let us go by because they knew we were with the World Health Organization. Okay. Oh. So, on the day that we flew into Sierra Leone, we found out that Sierra Leone had stopped all air traffic out of the country. So we got into the country, but we had no idea how we were going to get out of the country. But we had 3 weeks to figure it out. And as it turned out, when it was time, when our deployment was over, the World Health Organization was able to put together a USAID plane that took us. It was weird. We went to the airport in Freetown, huge airport, just nothing. No people, nothing there. They ushered 4 of us out onto this little jet. It took us on a quick little 40-minute hop to Conakry, Guinea. And Guinea was, they were flying out of Guinea. And so we spent the night in Guinea. And from Guinea, we flew to Paris and then back to the United States. So the World Health Organization was a great, very supportive group with whom to work. in that situation. So now let's get to the last part of this, which is the Presidential Commission on Bioethics. So I get back and I've kind of done a few of these different things, and I get a letter, I get an email and I get a letter in the mail asking if I want to come and speak, be a panelist at the Presidential Commission on Bioethical Issues. And I'm kind of like, well, why are you asking me? I mean, there were a lot of other people, you know, that they could have asked, but I thought, well, I'm not going to turn them down. You know, I mean, it was an incredible experience. And so it was at the tail end of the Ebola crisis, so it was neat to have done that whole process when they still had everything going on over in West Africa. So really what the Bioethics Commission wanted to do was create recommendations to support policies and practices so that we could be more proactive in future health emergencies like the Ebola crisis. Really wanted to look at public health preparedness and ethical preparedness, which was a huge piece of it. And they offered 7 pointed recommendations related to the outbreak of the Ebola virus. I'm not going to go through all 7 because they're wordy, but I'm going to go through 3, which I think actually are pretty germane to where we are now. So specifically what they wanted to look at was the U.S. response to the epidemic. And in particular, restrictive public health measures. We'll talk about that in a minute. Maybe some of y'all remember the restrictive health issues, healthcare personnel issues we had after the Ebola epidemic. The use of placebos for treatment in vaccine trials and sharing of biospecimens for future research. So what I want to talk about first is really the membership. I mean, I didn't know who was on this committee when I went. You know, I went running around the monuments the night before to try to calm myself because I thought, I don't know who I'm talking to in the morning. And it was just some of the people on the committee. Amy Gutman, PhD, who is the chair. She's the president, or she's a distinguished professor of political science at the University of Pennsylvania. James Wagner, who's the president at Emory University. Nita Farahany, who's the director of the Duke Science Society. I mean, you had people from just all over the country that had backgrounds in ethics and healthcare. And so that's who we actually spoke to, were the board members. And the panelists, we had 2 days of hearings, and they were from all over. I mean, let's see, we had, Luciana Borio, who was the Assistant Commissioner for Counterterrorism for the FDA. You had a PhD from the University of Wisconsin. I was there as a nurse. You had some people from CARE USA. You had a reporter from the Dallas Morning News. So there was another physician there who had worked with Doctors Without Borders. So there were people from all over the United States who'd had some sort of role in this epidemic. And so it was a very varied group of people. And just incredible people. So the recommendation 3 I want to talk a little bit about is that public officials have the responsibility to support public education and communication regarding the nature and justification of the public health response. So if you go back to the Ebola response and you go back to the 24-hour news stations, it was everywhere. I mean, some people were talking about the fact the virus mutated. Do you know what I mean? And so you're going to see all these various different strains. And some people thought that when people came back, they should be quarantined for 3 weeks. And so it was all over the place. And so the news that was going out to the public was not particularly consistent. And that was one of the issues. I mean, I don't know if you remember, but I remember sitting over in Sierra Leone in our little hotel. The second night I was there watching a 24-hour news channel, and they had this whole special on Ebola. And maybe I'd been there a week. And I was like, are we really talking about the same outbreak? Just because, you know, the media can so, once again, nothing against the media, but things can get so skewed. So one of the things that they really, really recommended is that we be consistent and in terms of what we report in the media. So really, people didn't pay a lot of attention about it until we brought those 2 missionaries back who got infected with Ebola, both physicians, and they were hospitalized at Emory. Remember, that was sort of the first Ebola that landed in the United States. And then all of a sudden we're like, oh, wow, you know, West Africa is only a 24-hour plane flight away, which is true. It's only a 24-hour plane flight away. And then, do you remember in October, there was the patient that got Ebola in West Africa, but was diagnosed in Dallas, and then the 2 nurses subsequent to that both got Ebola, came down with Ebola. So now Ebola, you know, so now Ebola is everywhere. I mean, that you just have to. It was just incredible, the outcry. So I just want to read briefly. I didn't really understand when I first went to this panel why we had this reporter there from the Dallas paper. And she was great. She said, what we've learned at the Dallas Morning News is that we had to have very consistent messaging and very, very, very repetitive messaging. So if one day I was on CNN 6 times talking about Ebola, 6 times I had to say, this is how you can get it, this is how you will not get it, and we could not overestimate how many times we had to repeat those messages, and we just didn't do that. This woman was phenomenal. Anyway, so that's kind of it from the media perspective. I have 2 more quick little things and we'll be done. Recommendation number 5, and this one really affected me. Government and public health organizations should employ the least restrictive means necessary on the basis of the best scientific evidence in implementing restrictive healthcare measures such as quarantines and travel restrictions. In addition, we should be prepared to communicate clearly the rationale for such measures and provide ongoing updates to the public about their implementation. So why did this all of a sudden become an issue for the United States? Well, it became an issue because you remember the nurse that came back from working with Doctors Without Borders, and she landed in Newark. She was from Maine, and they kept her in the tent outside the Newark International Airport for 3 days. And then finally, they let her go home to be quarantined at home. I mean, there was just no rhyme or reason about how we did this. And one of the things that happened with me, so when I came back, the tail was 21 days. I came back, got off the plane at 11 o'clock in the morning, and I was back working in the ICU the next morning at 7. Now, did I hug my children? No. Did I do any patient care? No. But I did go back to work, and the NIH did call me twice a day to get my temperature and to see if I was symptomatic. But that was the level, which quite honestly made sense to me. Because I'm not going to be infectious until I'm symptomatic. I'm in healthcare. And so, anyway, so there were issues with quarantine, and then some social distancing issues where a community college stopped taking students who said they were from confirmed, Ebola states. And the last thing I'm going to read, just because she did such a nice job, there was a physician who was on the panel with me, and she was in Liberia. And she said, at times it felt more challenging to actually coordinate our return to the United States than to do our Ebola-related work in West Africa. Returning home means not only managing risk, but also managing the perception of risk on an hourly basis. Even though we're asymptomatic, many of us choose to see limited or no family during that 21-day period. This is not due to fear of making them sick, but rather the public perception. We're concerned that our sibling, spouse, parent, or child will be sent home from work or from school because they have visited with us. And that's really how a lot of us felt. In fact, that's why I returned to the United States the day after my large family's Thanksgiving celebration. So that's another issue, a recommendation that the Presidential Commission made. And then there's that movie, Outbreak, that we've seen, right? And then the last one is to truly look at how we do clinical research trials during an Ebola epidemic. I don't know how many of you are familiar with clinical research, but you do a phase 1 study, phase 2 study, phase 3 trial. You see if it's safe, you see if it manages the symptoms. It's randomized, double-blind, placebo-controlled. You can't do that during this kind of outbreak. You just can't. I mean, it's impossible. So that's one of the things that they looked at, was trying to figure out how you can get good results that are clearly interpretable, acceptable to the host communities, and to the extent possible minimize delays to completing research. And I don't know if any of y'all saw this, but it was published in Lancet in December. This is from NPR. They have this great little series called Goats and Sodas, or Sodas and Goats. Anyway, so they have developed an Ebola vaccine that they gave to 5,000 people in Guinea during the very tail end of the Ebola crisis. They found it to be 100% efficacious. They probably haven't given it to enough people because nothing's really 100%, but it was very successful in in keeping people from getting the disease. They think the World Health Organization and the FDA have not yet approved it, but they looked at it'll probably be approved in 2018. And a global alliance has gotten together and raised $5 million, and they have 300,000 doses of this vaccine waiting for it to be approved. So it kind of tells you that a lot of the recommendations that came out of this presidential bioethics commission actually made it into policy. And look at that, perfect timing. That's it.
I think we have time for a few questions. Who would like to start?
Well, anyone who's done any risky traveling is familiar with the need for travel insurance. And obviously this work is at no small risk to you. Does the WHO insure you, like insure compensation if you get sick or hurt?
So the way the World Health Organization worked, it was a volunteer, endeavor. I think they paid us $1. And then they gave us a daily per diem, so that we could pay for food in our hotel. And then they did cover us with travel insurance because one of the physicians who was deployed with us did have to get evacuated to Emory. She did not end up having Ebola. One of the other physicians, not George, not myself, so there was only one other physician there, Ian Crozier, did get Ebola and was evacuated to Emory and was really probably the sickest person that's ever survived Ebola, and that was all covered by travel insurance through the World Health Organization. So yes, that was all provided. Yes?
What would you say was your biggest ally, maybe this didn't affect you personally, but in dealing with the mistrust that was so abundant and made it so difficult to treat this?
Well, once they were in the Ebola treatment unit, it wasn't hard because they were there, you were doing treatment, you were doing something for them. It was more the people who were outside, like the people who would see you out in the community. You'd have your World Health Organization badge on, so they knew you were at the World Health Organization. The only thing I could do was just to be incredibly non-threatening and friendly and smile and just hope that the fact that I was positive helped, allay their fears. I know it's kind of lame, but there wasn't really anything else I could do.
So, you talk about quarantine, and I don't know if this probably happened after you were there, but remember there was a huge disturbance in Freetown because they tried to enforce a rigid quarantine and people couldn't get food and so forth and so on. There was a major outbreak, conflict. Eventually they backed down. So, how do you feel about that kind of thing?
Well, the other thing that had happened across the entire country, the other thing I didn't tell you is that when we were driving through Freetown, no kids were in school. All public gatherings were canceled. And they had a fairly restrictive, I got a little scared going through some of those checkpoints, but, I understand the quarantine when they see so many of their own dying. Because you see, I was there for 3 weeks. These people had been, and I got there in August. these people had been dealing with the epidemic since May. So May, June, July, August. I was just there for 3 weeks. So I'm kind of this interloper that comes in and then leaves again. So I mean, they were weary, they were tired, they were, you know, they were sick, they were so scared. They were so scared. I mean, you know, like this Margaret Conacray, whose husband died and she adopted these young kids, she just kept saying, Kate, can you call my children? Are they alive in Freetown? And I was like, I can't, you know, and there was no way to communicate any of that back and forth. So, you know, it's just public education. One of the things that you noticed when you went to Sierra Leone is they've done a huge public health campaign against AIDS. I mean, there are billboards everywhere. I mean, and I didn't put any of them in here, but you would, I mean, you just would have laughing because, you know, the pictures were graphic. And so they had done a great job teaching people how to not transmit HIV to one another, not so much with Ebola because they hadn't seen it before.
So didn't St. Pat's become a spot for Ebola outbreaks had they occurred in the region? And what kind of reactions did you get from staff?
Well, you know, that's a really good question. So, you know, I was the manager in the ICU when I got back, and so I would talk to the manager of the, you know, the care and isolation unit at Emory, and she's like, Kate, you know, I mean, 2 patients, it just maxes out your staff. They do 4-hour shifts, you know, so, and they had the same issues at Emory that we had here at St. Patrick Hospital. Not everybody wanted to take care of these patients. We had to make it voluntary. You can't force people to do it. And then we had to finally just look at how many staff we had in the ICU. And it's a 25-bed ICU, so if you close down 3 of those beds and you make them care and isolation unit rooms, and you have 2 really sick patients in there, and you're cycling through 2 nurses, because 1 nurse has to be in the room, 1 nurse has to be out here, 2 nurses every 4 hours, you run through your staff in no time. Emory had 3 other ICUs from which to take staff. Omaha had other units from which to take staff. The NIH did. We were really the only small community-based hospital. And so there were some nurses who, and it was totally voluntary. They could work in the care and isolation unit if they wanted to, or they didn't have to, because you just couldn't mandate it. But then there were some people. There was one nurse, for instance, who rented a room here, and you know, I understand the public outcry. You know, the house where you rented a room, the owner was like, well, you know, I don't know, if you're going to take care of those Ebola patients in the care and isolation unit, I just don't know if I want you living here. I understand it. My perception was very different. So the nurses were great. I mean, they really were. If they didn't want to do it, they didn't have to, and as it turned out, we never had a patient in the care and isolation unit. So, good news. Yes?
I know you said this virus is a hemorrhagic virus. How was the access to municipal blood over?
Now, there's a really good question. So, actually, the hospital where we were, they did have a blood bank.
Okay.
And we could draw, and we probably could type and cross people for blood, but we were so resource poor. I mean, we had the ability was there, the personnel wasn't there. You know, when you give a unit of blood with patients, there's always an issue. They're going to have some sort of anaphylactic reaction. You have to sit with them for a long time, and we just didn't have the personnel to do it. And they didn't have that amount of blood either, you know, in the blood bank. So, but that's a great question.
Was the outbreak at all? Would that have decreased mortality rates?
Yeah, probably if you'd had enough of it, you know. But we did pretty well just giving patients normal saline and lactated ringers if we could get them to keep their IVs in, and we could actually deliver the fluid, because it was all hydration.
Well, this has been
All right.
a great kickoff to the lecture series. I want to mention about next week. So next week we have Linda Jacobson here to talk about the Global Health Service Partnership, a novel approach to addressing human resources for health. So I think that's going to be very interesting as well. So join me once again in thanking Kate Hurley for